Presenting sort of some thinking around kind of spectrum bias and differences in sort of diagnostic accuracy between different populations and how they overlap between tests and things that was all published in a perspective piece in Lancet Microbe a month or two ago. Co-authors on this include Jason Andrews, David Dowdy, Claudia Denkinger, Aditya Kadamanchi. But I think it's helpful to, yeah, I think it's worth talking through some of these ideas up January 2025. It's actually January 2026. So this and a lot of this perspective was in some ways inspired by us working on some modeling of TB screening and realizing how important it was to think about how algorithms perform and estimating that in ways that's not as straightforward as either taking our typical estimates from diagnostic accuracy studies or taking just estimates of accuracy of individual tests and multiplying them together. And so it was inspired by thinking through some of the complexities of modeling how screening algorithms perform in terms of case detection. But I wanted to start off by, and I'll say this is intended to have plenty of time for discussion at the end, but do feel free to interrupt me if things are unclear, or maybe Finn as moderator, if there are questions that you think in the chat that is worth pausing to address rather than wait for the end, please jump in. I won't be able to see them myself, but I'm happy to stop. So, wanted to start with just kind of a few statements that you hear made or about diagnostics that maybe are kind of based on some unfounded assumptions or not thinking through all of the considerations that you really do need to that are important when thinking about diagnostic accuracy. So I have a few slides of these that just want everyone to reflect on in terms of what problematic assumptions can you identify in sort of each of these statements, and we'll come back to them at the end of the talk. But what if someone told you our new test has a sensitivity of 80%? Great. Or their new test, oh, it only has a sensitivity of 80%. Or if we have a new biomarker and we say we're estimating that it's 90% sensitive and 80% specific for culture positive pulmonary TB, and that matches the targets in a recent target product profile for a high sensitivity, high specificity screening test. So our test meets that target product profile. Or if I say this test only has a sensitivity of 50%, that's really low. It's not going to be a useful addition to our diagnostic toolkit. Or I have a novel test in initial diagnostic accuracy studies, we're estimating that its specificity is only 96%. So it's not going to meet target product profile for a screening test of having 98% specificity. Or maybe I'm comparing tests and thinking about sort of importance of sensitivity and the sort of ultimate ability to increase case detection. And I say screening test A is more sensitive than screening test B, and on other characteristics like turnaround time and cost, they're similar. And so screening test A is going to find more TB and have more health impact than screening test B. Like, when is that not true? And then last of these slides, in a modeling scenario, say we're modeling TB screening and we have a screening step with a sensitivity of 70% and a confirmatory test that also has a sensitivity of 70%. And so what's the sensitivity of the algorithm? Are we then going to find 70% of TB in the population? Is it the product of the two? Is the algorithm going to find 49% of TB? And then finally, say I have a test, something like chest X-ray, and we have accuracy estimates in kind of sick patient populations. I know that its sensitivity is going to be lower in a general population screening context where there's milder disease. So I'm going to take prevalence survey data to estimate the sensitivity of this test. And I'm going to take among all of the identified culture positive TB in a prevalence survey, I'm going to look at what proportion was chest X-ray positive. And that's often how we estimate sensitivity of chest X-ray in screening. As I said, we'll come back to these. They're just something to kind of reflect on as I walk through the next several slides. But I think sort of an underlying kind of issue here that all of those examples are trying to get at, and that is really sort of motivating the sort of piece that I'm presenting today, is that too often when talking about TB diagnostics, sensitivity and specificity are treated as fixed characteristics of the test. This is true when we take estimates from diagnostic accuracy studies that are in people sort of presenting to healthcare systems with classic TB symptoms, and we apply those estimates, those numerical estimates, to screening contexts. It's true when we have algorithms with multiple test steps and we multiply estimates of how the different tests perform, assuming that they're independent of each other. It's true when we assume that our reference standards, whether that's culture or some kind of clinical judgment, composite reference standard, are perfect gold standards. And it's true when we're thinking about impact of our diagnostic tests. It's true when we assign equal value to all true positives and equal harm to all false positives, and we are interested only in the sort of proportion of cases that are detected, rather than thinking about how that case detection plays out in terms of epidemiological or health outcomes. And I think as we're making efforts to expand diagnostic access in TB and working to develop more sophisticated testing algorithms and thinking about detecting more forms of TB, including potentially asymptomatic or even bacteriologically negative TB, we need a more nuanced approach for thinking about how our tests perform and how to think about and quantify things like sensitivity and specificity. And this cube is a representation of sort of the TB disease space and is meant to illustrate the fact that TB is a really broad spectrum of disease, and we could define that spectrum along a number of different dimensions. I've chosen 3 here that are all sort of related to different aspects of why we might care about improving diagnosis for a given subset of people with TB. And that could be, you can define TB severity along sort of clinical risk, who's at risk to have poor clinical outcomes if we don't find them. You could think about different varying degrees of infectiousness that different people with TB may have who we care about for public health reasons. You can think about people who face access limitations, either they can't access the places where current diagnostics are available or they can't provide the relevant specimens, and that we might care about diagnostics that are going to be able to reach the people who can't currently access diagnostic testing. And just thinking about sensitivity and specificity as a kind of simple proportion doesn't necessarily consider how we might care about different portions of this spectrum more, or give them sort of more weight in the goals of diagnostics. And this spectrum and different dimensions of the spectrum also become important when we think about how we estimate diagnostic accuracy and how we translate those estimates between different settings and populations. I think it's easy to think of something like sensitivity and specificity as just a sort of a random sampling process where everyone kind of gets sampled with some probability and there's some proportion that you detect. But in reality, tests are kind of preferentially detecting certain portions of the spectrum. And it's theoretically possible for any given test to sort of delineate what are the dimensions along which, what disease manifestations does that test detect, and to conceptualize sort of the spectrum of disease along a corresponding axis or axes, and sort of, think about who the test detects and doesn't. And these 3 sort of dimensions that I've kind of illustrated here of clinical risk and infectiousness and access correspond roughly to the dimensions of disease that different tests are getting at. For a pathogen-directed test on a respiratory sample, like a sputum molecular test or tongue swabs or sputum culture are pretty are getting at bacteria that are being excreted from the respiratory tract and correspond fairly closely to infectiousness. Whereas markers of inflammation or host response may, at least in the short term, correspond closely with clinical risk. And then tests that are require a sort of advanced laboratory or a specimen that's hard to provide may only be detecting people who are on the near end of this access limitations axis. And you can, because different populations, because the TB in different populations may lie in different parts of this sort of disease space cube, it's really the threshold of detection, sort of where is the line between the portion of the disease space that the test detects, sort of the orange or blue or green, versus the portions that it doesn't, that are more of an intrinsic characteristic of the test rather than any numerical estimate of sensitivity or specificity. And part of the reason that it's important to think about tests in terms of what portion of the disease spectrum they detect is that different tests tend to have correlated results. This is particularly true when we're thinking about different tests that are detecting very similar manifestations of disease. Like, for example, we mentioned excretion of bacteria from the respiratory tract, which a lot of our diagnostic tests are getting at, whether that's sputum culture or a sputum molecular test like Expert, maybe a tongue swab, that all have different degrees of sensitivity, also have maybe some differences in terms of what's sort of what gene they're detecting and how prevalent it is, how many copies there are of that in the genome, or like whether the bacteria have to be viable or in some certain kind of replicating state to be detected. But pretty closely, these all lie along the same dimension with just different limits of detection. This is also true even when we're talking about different tests that detect different manifestations of disease, because all of those different manifestations tend to be linked to some underlying disease severity. You still end up seeing pretty strong correlations. These are just a few examples, 3 different studies that are looking at 3 different types of diagnostic tests: a transcriptomic signature, a more non-specific marker of inflammation in CRP, and a chest X-ray CAD algorithm. And all of these are stratified by people with low versus high sputum expert semi-quantitative grades. And for all of them, you see, sort of higher sensitivity of these tests that are detecting something other than the bacterium, but higher sensitivity in the people who have higher sputum bacterial burden, as indicated by Expert. And those correlations matter in part because of how they influence the accuracy of algorithms. We often combine different tests into algorithms for diagnosing TB. When we're talking about screening a low prevalence population, then that can be kind of multiple tests applied serially, where the goal is like identify a higher risk subpopulation and then perform an additional test. And people are positive if they're positive on both. Or when we're trying to detect TB in a group that are high risk, but TB is difficult to diagnose, then we may use concurrent testing algorithms, maybe something like a sputum test plus a urine lam, to try to increase sensitivity. And if we assumed that tests were independent of each other, then this is how those multi-test algorithms would play out in terms of combined sensitivity. Here, I'm just hypothetically saying there's sort of test 1 along the x-axis, test 2 along the y-axis. Each has 50% sensitivity, sort of along the x-axis. Half of the black dots, which represent people with TB, are in the purple, and along the y-axis, half are in the blue, are test positive. And if you assume that TB is just equally distributed or randomly distributed across this space, then the sort of sequential testing algorithm where both have to be positive ends up having sensitivity of 25%, and a concurrent testing algorithm would have a sensitivity of 75%. But in reality, disease isn't randomly distributed, and even for sort of whatever two different dimensions of the disease spectrum that we define, most TB tends to lie along the diagonal. There tends to be correlation between these different manifestations of disease that result in kind of most of the disease being in the sort of upper right or lower left quadrant. And that changes the performance of these algorithms. It increases the sensitivity of the sequential algorithm to around 40% in this example, and conversely decreases the sensitivity of a concurrent algorithm. If you're thinking about specificity, it would have the opposite effects. Decreasing the specificity of a sequential testing algorithm and increasing specificity of a concurrent algorithm. And switching now to a different way of visualizing these relationships, sort of instead of thinking about where disease lies along the disease spectrum, thinking more about using Venn diagrams to illustrate correlations between different tests and just what proportion of all people with TB different tests are detecting and how that overlaps between different tests. And this is an example of how accounting for these correlations can matter in a common TB screening algorithm, where we often test people with X-ray and then follow it up with a molecular test like sputum expert for confirmation if the X-ray is above a certain threshold of abnormality. Now, the chest X-ray is measuring lung pathology, the expert is measuring bacterial DNA in the sputum, but both of them are correlated with underlying disease burden. There's limited and variable data in terms of what the sensitivities actually are for finding all culture positive TB in general population screening, but reasonable estimates might be that Expert Ultra detects 75% of culture positive TB, so like 3/4 of the yellow oval is also inside the orange oval, and that chest X-ray has a 65% sensitivity, say. And but here, even though chest X-ray sort of detects the majority of TB, most of the TB here that is expert negative, culture positive, is also chest X-ray negative. Lies over here in this portion that neither of the tests detect. In other words, they're correlated. And in this example, the sensitivity of the sequential screening algorithm, where you're positive if both tests are positive, if they were independent, you'd have a 49% combined sensitivity, but accounting for these correlations increases case detection estimates by about 20% to a combined sensitivity of 60%, meaning that 60% of the culture positive TB here is inside both the orange and the gray ovals. But this is not, so introduce this for algorithms to then also look at how similar concepts apply when we are moving between study populations and when we're thinking about different reference standards and how they perform. So you can talking first about study population. Whenever we're evaluating a test or applying a test, there's some process that we use to select the population that's going to get tested. There's some selection even when you're trying to screen the entire population. But most of the time, we're not screening the entire sort of population the same way that it would be sampled in a prevalence survey. Often we're targeting some risk group or some people who are seeking out care for some reason. And those selection processes function in a similar way to an initial screening test, in that they select some subset of the population that may represent a different spectrum, a different portion of the overall disease spectrum. Like, for example, if you choose to do a test at a tertiary referral center among people who have been identified as having possible TB, then you're selecting people whose TB, if they have it, is likely to be relatively severe. And this affects how we estimate sensitivities of a test. Here, a hypothetical novel test in this illustration has a 45% sensitivity for culture-positive TB in the general population, meaning that 45% of the yellow area is also inside the orange area. But if we are using a chest X-ray, like as a screening test, to select the population that's getting this novel test, then among the people who have a positive chest X-ray screen, that sensitivity of the novel test increases to 65%, meaning that 65% of the TB that's inside both the yellow culture positive oval and the gray chest X-ray positive oval is positive on the novel test. Or similarly, or like alternatively, if we're performing the test among asymptomatic care-seeking patients, that's a sort of similar selection step, maybe even more strongly selecting for the sort of more severe disease that's likely to also be positive on the novel test. And in this illustration, that increases the sensitivity of the novel test among the population that's care-seeking to around 80%. This increases because of correlation between the population selection mechanisms, like symptom-driven care seeking, and the manifestations of disease that the novel test detects and measures. And then kind of last point on sensitivity is that these same kind of considerations of overlap and in correlated detection of disease manifestations across different tests also applies to reference standards. Our reference standards aren't perfect. We don't have a test that can detect this overall circle of people with TB, and even culture or some kind of clinician judgment, or whether it's sputum culture, whether it's some kind of composite reference standard that also includes some clinician judgment, we don't have a test that cleanly identifies this outer circle of people with TB perfectly. And our reference standards are also correlated with other tests that with an index test that we might be evaluating or with a diagnostic test that we might be applying. And so it's these same considerations apply in terms of what reference standard we choose or we use affects how we quantify sensitivity. And often we're thinking about sensitivity relative to a culture reference. And say this novel screening test has a 45% sensitivity for detecting all culture positive TB if we were even able to detect all culture positive TB in an unbiased way. But often, like if this novel test is a screening test that we are wanting to use at scale to look for TB in the entire population, then we're probably not going to be doing a confirmatory test, doing culture as a confirmatory test for everyone who screens positive. And I mean, maybe there are some novel tests that we could think about using as a sort of single step test and treating everyone who's positive. But if we're developing a test for use in a sort of two-step screening algorithm, then maybe it's more relevant to estimate sensitivity relative to the test that's actually going to be used for the confirmatory step in practice. And often that's something more like expert, some kind of molecular test that's going to be a little bit that's going to be faster and cheaper than culture and more feasible to use at a large scale. And if that's going to be the algorithm that we apply, then there's really no benefit to finding people who are culture positive and expert negative. Like there's not much value in a novel test detecting those people when we're talking about this diagnostic use case. And so maybe we should be focusing more on estimating the sensitivity relative to the test that is going to be used as a confirmatory test in practice. So lots of considerations around sensitivity and just a couple slides to point out a couple of ways that these same considerations also matter for specificity. And one of those is correlations. And here I'm illustrating, again, sort of a chest X-ray screening with molecular confirmation type of screening algorithm and thinking about how specificity plays out in that kind of diagnostic use case and algorithm. And say we're estimating chest X-ray as being 80% specific. in the population that we're screening, and say that expert has an estimated 99% specificity. We'll think more about the specificity of expert in the next slide. But if we assume that chest X-ray and expert are uncorrelated, then as a proportion of all people without TB, these two tests are independent. The amount of overlap is illustrated here. It ends up being a false positive rate of just the product of 1 minus specificity for the two tests, or sort of 2 per 1,000 that get a false positive result on the combined algorithm. But in reality, in populations with a high burden of TB, a major mechanism of, or a major source of abnormal X-rays can be prior TB, either previous TB treatment or maybe TB that people had that resolved spontaneously that they didn't know about. And that is also a large source of, probably the main source of false positive molecular results. And so suppose that this sort of correlation, this association of prior TB with both abnormal expert, like positive expert results and abnormal chest X-rays induces some correlation where half of the positive expert results are among the people who also have abnormal chest X-rays. That'll increase your false positive rate a lot. In this illustration, it's a 2.5-fold increase, so that you get 5 per 1,000 rather than 2 per 1,000, and the false positive rate gets a lot closer to the number of true positives that you would expect in a population with sort of a even relatively high TB prevalence for a kind of general population screening intervention. And then lastly, thinking about also the sort of selection of study populations and reference standards and how that affects specificity. I mentioned that we would think a little bit more about the specificity of expert. In the sort of most recent update of a Cochrane systematic review for Expert Ultra, its specificity for pulmonary TB among care-seeking adults is estimated around 95%. And you often see that estimate applied to community screening contexts. But in reality, it's pretty straightforward to sort of, if you think about data that are available, to know that specificity in community-wide screening has to be quite a bit higher than that. There are studies where an effort was made to screen the general population and the proportion of people who test positive on expert, whether that's, I don't know, the ACT3 trial, which was using an earlier generation of expert, or work by my own team in Kampala, Uganda, where we used Expert Ultra for general population screening. The proportion who test positive was less than 1%. And that sets a floor, even if those were all false positives, that sets a sort of floor on your specificity at 99% or higher. And then a lot of those positives actually are confirmed as being true TB, say, are culture positive, which increases the floor of raises the floor on that specificity even higher to something like 99.5%. And then even some of the people who are culture negative, further investigation can show that they really do have early forms of TB. For example, when we followed people with trace expert results for a year or two off treatment, something like a third of them were confirmed to have TB progression, indicating that that initial positive result that could have been classified as a false positive actually was true early TB. So that raises your estimate of specificity even higher, to where I think we have pretty good indication that the specificity of Expert Ultra in community-wide screening is well above 99%. And one possible explanation for that is the fact that culture is an imperfect reference standard, and that plays out differently in different populations. If you think about the test results that get classified as false positives and contribute to sort of 1 minus specificity, it's a combination of the actual false positives, like people who don't have the disease, and false negative results on the reference test. People who do have the disease but test positive on the reference. And when you're comparing to culture, culture is not a great reference for necessarily detecting all of the TB in a culture misses some TB, and that plays out differently depending on the prevalence of TB in the population that you're detecting, for the population that you're testing. And so here the false positives are the blue, either the people over here with TB who are test positive and not culture positive, and all the people who are test positive over here in the not TB box. And the sort of relative sizes of the TB versus the not TB box determine how much those test positive culture negative people with TB are contributing to your overall estimate of specificity. If we increase the prevalence of TB among all of the people getting tested, then those sort of false negative reference tests, so the blue portion over here on the right, end up being a much larger contributor to the overall loss of overall estimation of 1 minus specificity. So to summarize, sensitivity too often is treated as a fixed characteristic of the test, when in reality, you need to also think about the population you're testing, what other testing steps it's combined with, what reference standard you're using to evaluate it, and I think a useful way to think about it is to think about what portion of the disease spectrum each of these tests, population selection step, any test steps, and any reference standard that you're using to define the denominator of sensitivity and specificity estimates. What portion of the disease spectrum are they each detecting, and how much do those portions of the spectrum overlap? And for our algorithms, how much do the different tests overlap? And then I think it also, we need to be thinking about how test performance may be different in high priority subgroups and how that plays out in terms of health outcomes that we care about. And then we've looked at some of the ways that similar considerations apply to specificity. Returning to these opening questions for a few minutes, when you're making claims about the sort of sensitivity of it, or like just citing sensitivity of a test as a sort of fixed number, becomes problematic because these claims aren't saying in whom or relative to what or how the tests will be used. And depending on your reference standard and your population, a sensitivity of 80% could be really favorable or unfavorable. And then this next claim about a biomarker with a given sensitivity and specificity, it's now defining the reference standard, but still not the population. And often initial estimates of sensitivity and specificity for a new test are coming from kind of more sort of sick clinical populations compared to the actual target population of a screening test. And those initial sensitivity and specificity estimates may be misleading in terms of whether a test is actually going to meet targets when used as a screening test in the populations that screening tests are actually intended for. This third example, we're saying like a test isn't useful because its sensitivity is only 50%. I think it's getting at a different aspect of this, that it's not just the numerical sensitivity, but also kind of incrementally, who is a test going to detect that isn't already getting diagnosed by existing tests and processes is an important consideration. And if you have something like, say, urine lam that is low sensitivity overall, but that detects a high-risk clinical subpopulation that's difficult to detect with other sputum-based tests, then it may actually still be really useful, even despite low numerical estimates of diagnostic performance. We had an example about specificity being low in initial diagnostic accuracy studies and comparing that against specificity targets for a screening test. I think we talked for expert about how this can't be applied directly, and specificity is actually a lot higher in screening contexts. But I think this is something to keep in mind more broadly as new tests are evaluated as for screening use cases but initially tested in kind of sicker diagnostic accuracy study populations. This example of two tests with differing sensitivity and otherwise similar performance, I think the caveat here is that it matters what your confirmatory test is going to be. And for a screening test, it matters both what proportion of overall TB in your screening population is going to test positive, and does that positive proportion overlap with the portion that are going to be positive on the confirmatory test. And say if you're comparing an initial sort of respiratory bacteriologic test versus chest X-ray, and the confirmatory test for both is going to be another respiratory bacteriologic test. You may get higher sensitivity on the combined algorithm due to correlations from the sort of respiratory bacteriologic screening test, even if the sensitivity estimate of that test is lower than the chest X-ray. These last two, I think the algorithm sort of independently multiplying sensitivities of different steps, I think we kind of covered, but the true sensitivity of an algorithm like that is going to be somewhere between the just sort of the 70% that you would get if the tests overlapped perfectly and the 49% that you would get if you assumed independence. And then finally, this example where you could use prevalence survey data and all of the TB identified in a prevalence survey as a way of trying to estimate the sensitivity of chest X-ray. But the problem is that the people who are chest X-ray negative and asymptomatic get excluded from the denominator in typical kind of prevalence survey designs. And so this will end up overestimating your sensitivity. So to quickly sort of go through some recommendations and then open this up for discussion. I mean, I think in terms of how we perform and report diagnostic accuracy studies, it's because applying accuracy estimates requires context-specific interpretation. It's important for people who are generating the data to describe the setting, how the population is selected. It's useful to pair novel assays with comparator tests like experts, cycle thresholds, or semi-quantitative results, or CRP, that we can use to kind of to understand the severity of disease in the population and help in translating it to other populations. On the specificity side, it's helpful to also characterize sources and correlates of false positivity, and then either giving stratified results or ideally making individual level data available can help researchers and modelers and implementers in translating accuracy estimates to new populations. From a test correlation standpoint, it's also particularly useful to evaluate the algorithm components of the same test from different tests in the same individuals if they're likely to be used together, and to report correlations of sensitivities and specificities. In terms of setting accuracy targets, things like developing a TRP or just talking about and thinking about what accuracy we're aiming for in different test evaluations, I think, again, it's important to keep in mind that numerical accuracy varies by context, and to specify the intended setting and target population and reference standard when we're talking about accuracy targets. And then I think as modelers in particular, it's important to think about the ways that diagnostic objectives extend beyond simple accuracy, and to think about places where it's important, where different subsets of the sort of target population have different health or epidemiologic consequences, and to consider whether accuracy needs to be estimated differently in different subsets of the population in order to appropriately capture the ultimate impact of diagnostic tests. Finally, when we're modeling performance, I think these same considerations apply, that because sensitivity and specificity vary between populations, we should, when possible, prioritize data that are coming from contexts similar to the ones we're modeling. And when we have to extrapolate from other settings, can think about doing things like reweighting performance in different subsets of the kind of testing population to better align with the sort of distribution of those characteristics in the population that we're modeling. When modeling algorithms of multiple steps, it's important to think about correlations and how the tests perform together, how a follow-up test performs in the subset of people that test positive on the screening test, for example, and then to think about how diagnostics add clinical and public health value, and how they play out in terms of health relevant outcomes beyond just the proportion of cases detected, like really thinking about incremental impact in different priority subpopulations. I'll end there. Thanks again to the co-authors who contributed to this perspective article that I've been essentially presenting today. And I'd love to spend the rest of our time on some discussion I mean, could potentially talk about approaches or data needs as modelers, but also happy to discuss any other aspect of this.
Fantastic. Thank you so much, Emily. That was really interesting, especially for somebody who's not really involved in that side of TB modeling very much, a really important one. Does anybody have any questions, or do you want to leave up the slide with potential discussion points maybe as well?
Sure. Sorry, I've exited out of my sharing.
I think the one about data was particularly something that I was trying to get my head around, because again, I'm not familiar with a lot of this, but I was wondering where some, you talked about other data that we need to improve our understanding. And I was thinking a bit about that and where do the data come from? And I guess from my sort of very naive perspective, which are the data that we can trust, I guess, with all of these different considerations. That was
Yeah.
musing, but if you have an answer to that, then
No, I mean, I think that's a point for maybe broader discussion. I mean, I think there are efforts to do some of this. Like, for example, I used a lot of the example of screening algorithms with X-ray and, with or without symptoms, followed by molecular tests. I mean, I think there's work ongoing now to try to, both in terms of data to try to get at what how much TB is there in the sort of X-ray negative, symptom negative space that prevalence surveys don't typically sample, and sort of what can we infer from the data that those prevalence surveys do generate, but then also, some studies that are being done now that are, I think mass molecular testing is finally becoming more accessible, even with, sort of swab-based near point of care tests that are, sort of finally available in the last year or so, that have sort of potential to finally do more of that population-wide screening. But yeah, combining that with X-ray and symptom data to understand that kind of dark matter of who's X-ray and symptom negative is one example. But I'd be interested to hear other thoughts. And I think these considerations, I think a lot about TB screening, but there are other, I think, applications where this is relevant too. Certainly latent TB is a complicated one that I didn't get into at all. Pete.
Hi, yeah, this is really nice, and I must admit I haven't yet read the piece, but I'll put it on the list for discussion. So the question, therefore, I'm couching that just in case I'm asking something that's already in there and discussed. But um, as an additional complication, do you guys think at all about progression of symptoms? So, thinking about clinical pathways where people may have been tested at some point in time and then later on tested, and potentially their symptoms have changed between those occasions as well. So, I guess just the dimension of time, did that come up?
I did not go there at all here, but I think you're right in terms of those being, I mean, the correlation question applies there, in terms of repeated testing being correlated but not the same, and some potential to change, progress, or otherwise, or regress, or just have some kind of stochastic variability from one testing time point to the next. Yeah, I think you're right. That's that's important in any situation where repeated testing is happening. And also, when I'm talking about sort of clinical severity and who we care about finding, of course, those things change over time also. And you're just getting a kind of sort of cross-sectional picture when you're talking about who people detect, and the fact that someone doesn't have sort of high inflammatory markers or high indicators of infectiousness at a given time point doesn't mean that they won't progress later. Nick.
Yeah, I guess I have a question. I had questions, but Pete burgled my first one. But I'll try and answer your comment on your first discussion point first, because I think, right, that is an important one. Like, what do we do? Modeling is sometimes described as, the art of simplifying enough, but not too much, or something like it. And so I think it's reasonable to know that it's complicated and there's lots of, differences, yet not represent all of them in the model. My hot take on that one is maybe there's different roads for different applications. And so for one, the sort of the mechanistic approach where one does try and represent in the model the different kind of underlying disease states, which they're represented by differences along those dimensions you mentioned in terms of, sputum load, ease of taking a sample, access to healthcare, all of them are represented in the model. And then you might be able to have kind of parameter values that are the same across locations. Or there's a phenomenological approach where that your model is averaging across things that are different and that differ across locations. But then what that means is that if you're doing a study in one setting, maybe if you're doing a study in a routine care setting where people are tending with symptoms, then you've got to use different values to a study with which is doing active case finding. Or if you're doing a study in Uganda, you should be using different values to doing a study in Brazil and that kind of thing. So that both can work, but you've got to know what you're doing. Actually, well, I'll let you respond if you think that's the way forward, and then I'll come back to my question.
Yeah, I agree that it's either kind of, and I guess the question there is like, are there different subsets of the population that you want to model differently, to the extent that these like different diagnostic performance is also related to other, like, I don't know, clinical or transmission or other outcomes that you care about, then that potentially becomes a sort of a reason to take I think what you're describing is sort of the first of the approaches that you're talking about, where you really are sort of mapping out different, but yeah. No.
Yeah, probably mechanistic and
Is a
phenomenological
third.
probably aren't quite right.
Yeah.
Okay, so this is the question. So in like a very early slide, one thing you mentioned was about consequences. And when I've been thinking about these things, I've tried to separate out, kind of test performance in terms of this classification of individuals into different categories from then what happens if we treat people appropriately or not appropriately. But some of your talk, made it clear that, those really are intertwined because, if we think about the different classes of individual who might test positive or negative, they'll be correlated with, infectiousness, or they'll be correlated with disease progression and all these kinds of things. So, do you think that, when we conduct these kinds of analyses, we should already be thinking about consequences, or can we separate things out? Because certainly analytically, it makes it very helpful if we separate out, test performance from, again, later outcomes.
Yeah, I mean, I think that it's something that you need to think about for the individual kind of what's the question you're answering? How heterogeneous is the population that you're representing? What are the outcomes that you're looking at, and how strongly are they linked to differences in, say, diagnostic performance? I think it's something to at least think about, and we make sure that you have good justification for kind of averaging everything together, which, good justification can be that the population's pretty homogeneous and the outcomes that we care about aren't really kind of directly related to differences in diagnostic performance. Or maybe it's that we don't have the data to understand how things play out differently and so the uncertainty introduced by trying to stratify this just makes it not worth doing. But I do think it's something that we need to at least think about.
Thanks, Nick, and thanks, Emily. Anyone else have any questions?
I suppose just a comment off the back of that other one, and I think my video's sort of broken. Oh no, it's back. Oh,
Yeah.
right, amazing. Sorry, it plays up with Zoom for reasons I don't really understand. Yeah, so I mean, I guess if Nick, you're sort of thinking in the direction of like including benefits in studies of diagnostics and sort of trying to do that kind of thing. I guess an issue is that the outcomes, like death, are rare enough to not fit easily within that kind of study, or even within existing study designs. To put it the other way around, you don't get often enough events to really say very much directly about any differences in those kind of next step down the cascade consequences. Is that sort of the direction you were? No.
You're muted.
Sorry, I wasn't thinking about the data in as much. I was thinking about, sometimes I take these and I try to map them onto something simple, which is like, so the early wrap on smear was that, okay, it missed a lot of people, but it caught those that were most likely to die and most likely to transmit amongst those that had TB. And so, that's saying that not all sensitivity is equal. And then if you now introduce HIV in a setting where there is not HIV testing, that could reverse that. Those who aren't testing positive with smear but still have TB, those are the people most likely to die. Maybe not to transmit, but certainly most likely to die. And so, this idea that, even if we had a perfect reference standard, how we approach that, again, I guess is, not all sensitivity is just as valuable. And so if we are able to maximize sensitivity for those that we most urgently want to test, that's a different thing. So I guess that's what I was thinking of. But you're right that if we want to collect data on later outcomes, you're right, deaths are rare, but also the study designs to collect those require, longitudinal follow-up that might not be available.
Right. Thank you both. Any last chance for a question before we run out of time anyway? Kathy,
Can I just throw in two questions? Thank you so much. I find it really interesting to ponder that sensitivity isn't, equal. And I understand that. I also understand the concept that obviously something that we don't tend to model at all is then also user error. Not all situations and environments where we are applying certain tests will actually perform equal. And that's something that we quite often don't actually throw into the mix and say, well, some technology might be very good in one place, but it might not perform so well in another place. And if you add that to it, then that might actually give you a totally different picture. So I don't know if you've played with that a bit. And the second question, totally different track, is the bit that you said where some people who appeared false positive in the test, and then what was it, 30% that you said turned out to be positive on follow-up. It might have potentially been sort of an early form of disease that wouldn't normally be picked up. I wonder what your suggestion is to that, because that, for me, from a practical point of view, would indicate that we actually need to think of testing more as a follow-up process as well, and not just say, oh, we tested them, they're negative, we sent them home. And that's when people get lost in the system, which is the usual case.
Yeah, so maybe to address the second question first, yes, I was saying that in a study where of the people who were like trace positive on expert ultra and community-based screening and negative on culture, that about a third of them were confirmed to have had TB diagnosed within the next year or two, and most of those people who didn't, like in retrospect, did have some abnormality on chest imaging. I mean, I think there, from a modeling perspective, I think that it's as we're like estimating false positive results or specificity, it's typically saying what people are going to be harmed rather than benefiting from overtreatment if we are relying on this test. And I think that's a situation where, as we think about, say, maybe mass molecular testing as a way of identifying people who would benefit from treatment, that maybe the sort of risk-benefit ratio is lower than what specificity estimates that are just just defined relative to culture reference standards would suggest, because there is, I think we have reason to, think that there is a pretty large pool of people who have sort of early culture negative TB, who even if they're kind of in the short term, less sort of lower clinical, risk, non-infectious, maybe a lot of them won't progress, but still like they'll benefit more from treatment than someone who really doesn't have TB. I wonder, I know we're short on time. I wonder if you had an example of your first question.
Well, we know that GeneXpert, for example, doesn't perform so well when things go hot. And a lot of areas where there is a high burden of TB are pretty hot places. I mean, GeneXperts just hate dust and heat. So their performance isn't as good in terms of sensitivity or, workability. Couple that with user error, people not being so well trained in putting samples into the mix. So quite often,
meaning that it's not just the patient population
characteristics. So the wonderful sensitivity, specificity that we get in our ideal setup test scenarios, they don't actually meet reality anyway. So I think we often overestimate.
Yeah, that's a good point, that it's not just
what we could reach.
Populations, but also kind of implementation.
And that is a big problem for us at the moment with modeling and trying to convince countries that there is actually a benefit to modeling, because a lot of them say, oh, we've been modeling now for the last how many global fund cycles, and yet we can never actually achieve the results that we modeled that we should find.
Yeah.
So I'm just wondering if there is any suggestions on, should we actually take that into account? Should we have another loop of maybe lowering expectations a little bit?
Yeah, I mean, I think in terms of what data we rely on, I think that's important for generating kind of pragmatic implementation data in terms of how things perform, and then in thinking about what data we draw on for modeling in terms of kind of prioritizing that kind of real world data, maybe rather than just kind of optimally conducted research studies as where we're getting our evidence. I'm going to have to run myself.
Yeah,
thank you all so much.
I was just going to say, thank you so much, Emily. That was really, really interesting. And I will stick a recording up online for anybody who wants to watch it again sometime as well.
Great.
Thanks a lot, everyone.
Bye.
Have a good rest of the day. Cheers.